thank you for being with us. Let's go ahead and call ourselves to order, please. And Dr. Minnicott, if you'll please do the roll call.
Yes, Madam Chair, we have Dr. Mercer,
Here.
Dr. Curry,
Here.
Dr. Cheek, myself, Dr. Brennan Taylor present, Dr. Rodriguez is absent, Dr. Williams, and Mr. Hopper is absent today. Madam Chair, we do have a quorum.
Thank you. Generally, we would vote to adopt the minutes at this time. With our transition, we did not have quorum 1 month, so we're holding out January, February, and March. So if we could just ask if those 3 months were sent to all board members electronically, and then we can all individually approve all those meetings. In the transition, 1 month was needing some slight corrections. And so if we could just look at January, February, March, then we can electronically approve it. Is everyone in favor of that?
I would recommend that we include April as well.
And to include this meeting also, great idea. That's a great idea. So we'll do January, February, March, and April, and electronically approve those minutes if that is satisfactory. Great, thank you. Okay. Well, Dr. Tooney, we turn it over to you.
Oh, thank you so much. Thank you, Madam Chair, board members. It's a pleasure to be here. It's been a busy month since the last time I saw you. And one of the things that we've all been working on have been program reviews. There's a template in your package that you can look at, very extensive indicators about individual programs, not big picture look, but really a very in-depth look at all the programs. So I was, I think, overly ambitious, thinking I could complete this before the end of March. I'm still going. I'll probably be going into the first week of June before I complete. I think it was a tremendous opportunity for staff to think in a different way about the programs and how they present it, and what some of the indicators are and how we should be measuring outcomes, not by counting the number of people served, but actually what is the impact of the work we're doing. It also allowed me to see some of the crossover programs and interconnection of programs where I haven't seen that before. One of the questions on the template, as you see, is what can Commissioner do for you? And I got some very interesting ideas about how I can actually make some connections that are very easy to do. It's very optimal timing for me. I'm meeting with the Department of Early Child Care and Learning on a regular basis around the gateway infrastructure. That's the one-stop entryway to state services. We're sitting next to each other. Well, there's an opportunity to have some of our environmental health programs collaborate with them on the environment within child care facilities. And so it was a perfect opportunity for me to be made aware in a way that I probably wouldn't have otherwise of a cross-agency collaboration that could occur. I think we also identified opportunities for collaboration internally that hadn't been evident initially. And several people have sat in on all of these program reviews to better understand the full scope of the program. So I'd say it was a tremendous commitment of time and effort, but well worth it to everybody who's participated. And I'm really grateful that we took the time and commitment to do that. And I think the staff will agree that this has been a worthwhile and productive learning venture. We're hoping to take the products of these program reviews and actually turn them into one-page summaries that we can share at the legislative session. That was something that I knew in my 3 weeks at the Capitol. There are all kinds of questions that we got about the programs that I was unable to answer off the top. And now we want one-pagers about every program that we can keep updated and serve as a tool to help legislators better understand what we do. So I think it's an investment in our future and good work ahead. The other thing to make you aware of is last week was the Georgia Public Health Association meeting. Many of our staff participated in that meeting, as did many others in academic public health and private sector. It was well attended, but I think particularly I appreciated the fact that Dr. Cordero, who gave one of the keynote speeches, Dr. Cordero from your institution, gave a very inspirational talk about maternal mortality, which is one of our priority areas and one of great legislative interest as well. And the other major talk was by Dr. Redfield, the director of CDC. He talked about his personal experience with opioid and the loss of his son, which was a very moving reminder that this epidemic has touched many of us and how this has to be one of our priorities. But he also talked about specific priorities with Georgia. And he had, as I mentioned to you at the last meeting, he had reached out to me, which is really unusual for a CDC director to reach out to a public health official and talk to me about particularly HIV and the importance of working on HIV in the HIV area with special funding targeting high impact areas. And we see that opportunity in metro area, that with his leadership and his assistance, we will continue to expand that initiative beyond metro into the state as a whole, developing what we hope will be a template or a model for intervention for HIV that can have an impact on statewide, rural, as well as urban. And his talk was very inspirational because it talked about the 4-county initiative, but also his intent to have that influence the statewide initiative. But I wanted to raise the two other areas that he thought that he wanted to work with us on. One was immunizations, which was something that is clearly of importance to us. We recently had a rule change, and there was a lot of interest in the vaccination rules. I think that we will see, just as you will hear today, with the measles and hepatitis A increase that we've seen here in the state, that immunizations will continue to be a priority topic for us. And with CDC's leadership and education and outreach, we can have broader reach. And so I think their leadership in this area, coupled with our work on the ground, is what's going to be needed to turn this around in Georgia. The other thing that he mentioned was the presence of Hartsfield. And Hartsfield is a potential entry point for emerging pathogens, Ebola, or whatever the situation is. Emergency preparedness is a key area where we need to think about how we can better collaborate with CDC. So that was a wonderful set of priorities. It really was in sync with our way of thinking, and was a great prelude to what will be my first visit to CDC with Governor Kemp. We are going to visit with Dr. Redfield on Wednesday,
Right.
and which is wonderful. He invited us to come take a tour of CDC with special discussion about the HIV initiative in Metro and then the potential for expansion statewide. So I'm looking forward to that visit and the potential impact. Wednesday. That's tomorrow. Oh, wow. Time flies when you're having fun. Tomorrow afternoon. So I think that will be a very productive meeting, and I think a potentially groundbreaking meeting for Georgia as we open up new areas of collaboration between the State Health Department and the Governor's Office and CDC. As I said when I introduced Dr. Redfield at GPHA, I've never known a director of CDC to reach out in this way to the state of Georgia. And he recognizes that our indicators, our health status is reflective of CDC's impact, and we can do better, and we can do better working together in partnership. And that was a very exciting presentation for us at GPHA. And the last thing I wanted to mention with you is that the National Governors Association Center for Best Practices had sent out an announcement about a special symposium they were having, or training they were having for states around access to care, maternal and child health, EMS, rural health, how we can integrate healthcare in a more effective way with the states, with multiple states participating, but that it was an application process. Georgia applied and we actually got the grant. And so we will be sending 2 individuals, as will the Division of Behavioral Health, Developmental Disabilities, and Department of Community Health. So the health agencies will be represented at this special NGA symposium training, which we hope will pay dividends, particularly as we move forward, developing, helping with a seat at the table to develop the Medicaid waiver and other activities that are happening. So that concludes my discussion of many of the things that are happening, and I'll be happy to take any questions.
Thank you, that's exciting. I think we'll get national probably coverage for that, and the CDC is invited.
Governor,
That's great.
thank you.
Tell the staff we're waiting on 2 more board members. Right there. Yeah, that year. Well, thank you. Now we're moving to the approval of the bond resolution. Ron?
Yes, hi. We're here today to actually go over the list of the 2020 capital general obligation bonds, and we're requesting $2.3 million. The actual board meeting in April, we submitted the list, and I just went back through and provided the list again for all the activities they have. It's for the Decatur and Waycross labs.
Thank you. Does this require any action on our part?
Yes, ma'am, is to get a vote, and I also will need signatures from the secretary and the chairperson.
I recommend we approve.
All in second? Okay, all in favor?
Thank you.
Thank you. And we're going to hear about our body art.
My favorite topic. So I titled it, Madam Chair, Board, opportunity, it's a pleasure to be here. I titled this free presentation, Tattoo of Body Art. You'll see why just shortly. Just to give you a little bit of history about tattoos, it's one of the oldest this body adornments. There's tools found across the country that date back over 12,000 years. The thing that I think that's important is what was once seen as a subculture is not a subculture anymore. It's very mainstream, and you can see from these statistics that 36% of Americans between 18 and 29 have at least one tattoo, and then we look at the ones that have more than one, and the numbers even go up even more. And 50% of Americans have at least one tattoo or piercing. And so the importance of ensuring sanitation in these tattoo facilities is critical, so that we're not causing a disease or actually causing the body artist to get some kind of disease. So we protect the artist as well as the person receiving the tattoo. I did want to briefly mention brief history. So one of the questions that came up at the last board meeting talked about microblading. And I need to kind of give you the history to get to microblading, to get to body art, because it is sort of an interesting history in our state. 1981 was really the first time that the state legislature passed a law that regulated tattooing. It actually had criminal laws associated with illegal tattooing. It was 94, though, when the laws were updated and actually provided authority to the then Division of Public Health and the local boards of health to adopt regulations around inspecting tattoo facilities. What happened, though, during that time was the division in the early 90s decided that the local boards of health would be the lead for this. There would not be a state tattoo regulation. This is a little different for most environmental health programs. Almost all of the environmental health inspection programs, the regulations are state rules, so we have consistency across the state. But this was the one program that was basically delegated out to the local boards of health. And as you can imagine, we have 159 boards of health. We, in some cases, have 159 different ways of this inspection and permitting occurring. And so one thing that the state environmental health program did at the time was work with the local environmental health offices to develop a model regulation. And a lot of counties are still using that model regulation that's over 25 years old. The industry has changed drastically in the last 25 years. So in 2012, one thing we wanted to do is start tracking the number of boards of health that had actually adopted some form of regulation. And as you can see, in 2012, only 134 county boards of health actually had adopted a local regulation to inspect tattoos. So what does that mean? What it meant was that we had a lot of facilities that were operating without any inspection program. We had a lot of counties that were being challenged by the industry that they needed to be permitted in order to get a business license. And so we started working with the counties in 2012 to ensure that there was local regulations adopted in every county. And as you can see now, we're up to 158 counties. Still doesn't have local regulations in place. But some of the issues that came about when you have local rules, obviously, is some counties are sticking to the traditional tattoo-only model, meaning that that is the only thing that they allow in a tattoo facility. But as many of you may know, in tattoo facilities, you also have body piercing, you also have now microblading, a lot of different techniques that are going on. And so there's a lack of consistency. Some public health districts adopted a comprehensive body art regulation. And so the industry was really complaining to the department that it's all over the board. There's no consistency. A lot of these artists go to different studios to work. And they have to get different licenses in different counties. So it's hard to do business in the state under that kind of model. And so the inspection forms were different, the application forms were different, and then in some cases they would not allow certain procedures that other counties would allow. From the department level, because it's was a local regulation, or is a local regulation, we can't really track things. We don't have a good surveillance system in place to track any types of potential injuries, or diseases, or anything, because it's handled 159 different ways. So that's created a lot of challenges for the agency and for the industry as a whole. And then lastly, some of the regulations that we have seen, really we're not sure that they're protective of all the risks that are potentially involved. And so body art is really the industry term that's being used now, because in a facility that is traditionally a tattoo facility, what we're seeing is you have body piercing, you have tattooing, you have cosmetic tattooing, and in some cases you have branding and scarification. So it's a litany of services that are offered across these particular facilities. With our statute being so old, and it only covered traditional tattooing, we really recognize the need to update these standards, to update these regulations. And the industry has really been pushing for this to be able to do that. And so the tattoo-only structure, I'm not going to read all of these things, but it gives you an idea of what the statute gave the local boards of health authority to regulate. Provided definitions of what a tattoo was. It allowed the issuance of permits, inspections, as well as enforcement and penalties. The reason that I mentioned the criminal statutes, it's important to mention that because in Georgia, when microblading became, I guess, the tattoo du jour now, there was this criminal statute that said you can't tattoo within 1 inch of the eye. And this really prevented the microblading community from being able to do the tattoo of the eyebrows, which is essentially what microblading is. And so they started working to try to get microblading added into the current statute and to get that removed from the prohibition of the 1 inch from the eye. In addition, there's other criminal statutes. In Georgia, no one under the age of 18 can be tattooed unless it's a physician providing that service. And then for piercing, no one under the age of 18 can be pierced unless it's the ear level where they have written consent from a parent or guardian. There's some criminal statutes that fall into this particular area that we regulate. But in 2018, the microblading industry, was successful in getting their particular type of service added to the tattoo statute. So now microblading of the eyebrow is listed as a legal form of tattooing. And it also removed the criminal piece, so it essentially exempts the 1 inch from the eye criminal statute. So you can legally do the microblading of the eyebrow and not violate that criminal statute. And this just gives you an idea. Microblading is essentially those two little devices in the middle of the screen, which has multiple needles. It's an extremely small little handheld device, and they manually basically scratch in the ink into the eyebrow. And there's probably more artistry to this in some cases. So the technique is important to make sure that it looks authentic. They've also now came out with a new mechanical device that does something very similar. And on the right is your traditional tattoo machine that's used. And you can see the difference. The traditional tattoo machine actually injects the ink deeper into the skin versus the microblading technique, which really just goes into the epidermis, the very surface layers of the skin. So in 2019, getting to body art. So the industry, again, even though they got microblading added to the law in 2018, they were still concerned about the lack of consistency across the state. And they started really pushing for a more comprehensive statute. The department was really limited on adopting a state regulation because the statute only says tattoo. And there's a lot of other services going into that particular, or in those studios. But the industry was very successful. They was able to get the tattoo statute revised. And so now, everywhere it said tattoo, it now says body art. And body art means, for Georgia, tattoo, cosmetic tattoos, which is the microblading as well as piercings. The other piece that changed is the licensure of the artist will come to the department versus every individual county. We already have licensure programs within environmental health, and we're going to model this after our current programs in place. And so what this will allow is the artist to have one essentially licensure card that allows them to go to multiple counties and to be able to do this type of work in studios that are still permitted and inspected by the local health departments. Our goal with this is to adopt statewide regulation. That's really been our goal from day one for a number of years. And we have been working with the local environmental health offices, the local district health departments, and they support this. They've actually agreed that we need a consistent regulation because it makes their job easier, especially for counties that are right on the line between one public health district and another. So we're working now that this, well, take back up. Governor Kemp signed the bill 2 weeks ago, so it's now officially a law. It goes into effect July 1st. And now we're working with the districts to start the implementation phase. So we have a committee that's been working on this particular regulation for a number of months now. We'll be sending it out soon for feedback from the districts and health departments as well as the industry. And then we'll go through the formal rulemaking process that will allow us to have a comprehensive body art regulation versus a tattoo regulation. We're also going to be working on developing the licensure program here at the department. And with that, we're going to have to work with a lot of work to educate the industry as well as the health departments and the artists to make sure they understand that they will have to be licensed by DPH versus the individual county health departments. And then the last piece, once we adopt all of the rules, then we'll start the implementation. Looking at a 12 to 18 month implementation period to give all the studios time to come into compliance with current regulations and to answer any of their questions and work with them over the next several months. And so that's the body art program in a nutshell, and we're excited that the legislature has passed this and the governor signed it. We're excited that we're going to be able to adopt a new regulation that's consistent. I think the industry, well, I know the industry is in support of this. I look forward to any questions you may have.
Well, excuse me, thank you so much for the presentation. Is there direct funding that comes to help develop this program and implement it? It came down to the legislature.
There was no direct funding, but we will charge the artist a licensure fee that will be retained in the restricted fund here at the department. And we're going to use those funds to help support the program. And that's how some of our other environmental programs. Yes, sir.
Do you have any thoughts? It's very interesting. It seems very systematically thought out. Do you have any data on injuries due to tattoos in Georgia? Or
very little data in Georgia because we have never had a good surveillance.
how about anywhere else?
There are some national studies that has been done that does show some data. What the data typically shows is the majority of the injuries occur in non-permitted, non-inspected studios. So we call them scratchers in the industry. These are the individuals that tattoo out of basements and, believe it or not, basements of restaurants and basements. They're on the fringe. They're not they don't want to be licensed. And so most of the injuries that occur in places that aren't licensed and permitted, and in jails, of course. There's a lot of illicit tattoo that occurs in jails.
And what is the number one injury?
A lot of the injuries are infections. So what typically happens is the equipment's not sanitized. Who knows how it was used before? I mean, we've seen tattoo machines made out of a simple battery, a little motor, and a guitar string. And so it is primarily infections.
And are henna tattoos addressed in any of these body art?
Henna is typically not injected, and so those are semi-permanent tattoos. As long as, if the ink is injected into the skin, then it would be addressed by this. If it's not injected into the skin, it's not considered a legal tattoo, or it's not considered a tattoo. It's more of just artwork on the skin.
And do you anticipate your regulations starting at age 18?
The law requires that,
The law.
yes. The criminal statute did not get changed, and so tattooing in Georgia legally, you have to be the age of 18. And that does not allow for parental consent.
You showed that 158 current boards of public health have regulations. Which one does not? Does it have facilities for tattooing?
It's Harris County, and the reason that county board of health chose not to adopt regulations is the county governing authority prohibits tattooing through their zoning code. And so their zoning code does not allow tattoo shops in the county. And so the board of health just chose, in their, I guess, argument is it doesn't matter if we issue a permit, if the county's not going to issue a business license, you can't operate. So they chose not to adopt regulations. However, when this rule goes into effect, all boards of health will be required to enforce it. So it'll probably spur some discussion in that county at that point.
Is there any way to remind folks that the tongue is a body part? Because the under 18, I see so many teenagers coming in with their tongues pierced and the parents are not aware. And so this statute that 18 or over, when did that come into effect?
So that statute only covers tattooing. Piercing is allowed with parental consent under the age of 18.
So it just depends on if the parent has consented, and most of the time they haven't, but.
That's correct. However, one thing that we can do, and I think it's important that we focus on the artists, the body artists and the piercers, that if they're under 18, they're supposed to have a consent form signed in the studio by a parent or guardian.
Is this a state form, or this is just,
It will be. Once we develop the new regulation, the forms and all those will be developed as well, so we're consistent. Questions? Thank you.
Thank you, Dr. Thank you. Let's see. Dr. Benedict, hello. Hello.
Madam Chair, members of the board, Commissioner Toomey, good afternoon. It's a great pleasure to be with you again this afternoon. So in our short time that we have together, I'd like to talk to you a little bit about a trilogy of public health emergencies that we've been working on over the last month. I'd like to talk a little bit about, provide you an update of our ongoing hepatitis A outbreak here in Georgia. I want to talk a little bit about measles outbreaks both nationally and here in Georgia as well. And I also want to give a brief update about an ongoing multi-state outbreak of E. coli 0103 infections that are associated with ground beef consumption. And then we'll have some time for questions. So first of all, let's start with hepatitis A, as we talked about last time that I was here with you. So I wanted to provide you with, again, a snapshot of the ongoing outbreak and the epidemiology of such. Again, these numbers are current as of May 10th, or May 3rd, I'm sorry. So now we statewide have now documented a total of 312 confirmed hepatitis A infections. The last time I was with you a month ago, it was 214, so almost 100 more in a month's period of time. Although the epidemiology and the affected populations really hasn't changed much at all, again, we're seeing A as well. In regards to the geographic distribution of where these hepatitis A cases are occurring in our state, again, this also has not changed since last month. Our northwest corner of the state, our Rome district, really is again the hot spot of this particular outbreak, and it really was a direct extension of the large Tennessee hepatitis A outbreak from Chattanooga down into our Rome area. But other hot spots in the state include the Augusta area, the Atlanta area, primarily Fulton County, and we're seeing a little bit more in our coastal area as well. And if you sort of break this down, this next graph really by our public health district, again, 137 of our 312 cases have occurred in our Rome district, and our Augusta district now has been seeing kind of the most recent increases, and they actually are come in second place with a total of 55 hepatitis A cases as well. The last time I was here to present to you, there were actually many of our public health districts that didn't have any hepatitis A cases at all, but now I can say that all of them have at least one. Although again, we haven't really seen wide, sort of geographic spread here. It has been concentrated in these same really kind of 4 areas throughout the outbreak. And again, if we take a quick snapshot of the risk factors of our population that is most affected by these infections, again, almost half of them report illicit drug use. And if you break that down into whether they report or self-report injection drug use or non-injection drug use, you can see that about 65% of them report injection drug use, 73% non-injection drug use, and 45% report both. So again, the reason that, although some of these self-reported data may indeed be limited, we want to, again, try to delve into this epidemiology as deeply as we can so that we can target interventions, primarily vaccination, to these populations at greatest risk. So it allows us to see that really the non-injection drug users, and which, according to self-report, is primarily meth users, are there ways that we can better target this population at risk to try to, again, make an impact in stopping the spread of these infections? So really our overarching response strategy, as I had mentioned last month as well, is really to target our vaccination efforts to the population at greatest risk. Our DPH health departments in the affected areas and really all around the state have administered, almost 3,000 hepatitis A vaccines to populations at risk, and we continue to try to think of innovative ways to reach this population that is actually historically very difficult to reach. And we also have been targeting our vaccination efforts in response to infected food handlers. We have documented a number of infected food handlers that have had hepatitis A infection that work in restaurants that really pose, again, not a large risk of transmission, but it gives us an opportunity to, again, offer vaccine primarily to their coworkers in the restaurant industry. And again, the risk to patrons really has been quite low, but it allows us, again, perhaps to reach a segment of the population that may share other risk factors as well. So our parallel response strategy, besides vaccination and targeted vaccination primarily, is again education. Education to healthcare providers to screen for these risk factors, offer vaccination. And we've been focusing on emergency departments. The state of Tennessee and the state of West Virginia, who have also had large hepatitis A outbreaks, have had a tremendous amount of success in kind of targeting their emergency departments to screen for these risk factors. So we've worked with those states to modify some of their materials to share with emergency departments who sort of have a decision guide about screening and offering vaccination, NEDs, to individuals that may share these risk factors. Dr. Toomey actually sent out an electronic, sort of a letter to all healthcare providers in Georgia on April 19th, again, reminding them about this outbreak and about the importance of hepatitis A vaccination, particularly among individuals that have these risk factors. And we've also been reaching out, again, to a number of different groups. Again, the Georgia Restaurant Association, to remind them about, again, offering vaccination as appropriate to individuals that work in restaurants. Not that that indeed is a risk factor in and of itself, but again, they may share some of the other risk factor categories. Second in our trilogy is measles.
Can I ask you, while we talk about
Sure.
measles, if we're targeting the emergency departments, are they also offering the vaccine?
Yes.
They are.
Yes, in many cases, so in the private sector, again, they may have access to vaccine. One of we're very excited, one of our greatest success stories is as a direct result of Dr. Toomey's healthcare provider communication. The emergency department in the Grady Health System actually reached out to us and said that they feel that, again, much of their emergency department population may have these risk factors. And again, they wanted to partner with us and also started an initiative where they indeed will screen everyone and offer vaccines. So we're really glad to see that as well. All right, number 2, measles. So I like to say, and as again, those of us in public health practice say this a lot, everything old is new again, right? So here we are dealing with these huge numbers of measles cases here in the United States and these outbreaks. This year alone in the US, there have been 839 cases of measles that have been documented through May the 10th from 23 states with 9 different outbreaks. And several of those outbreaks are huge. Of course, the New York outbreak, the Washington State outbreak. And this is by far the highest number of measles cases that have been documented in the US for more than 25 years. The vast majority of these 839 cases of measles were unvaccinated. And the epidemiologic pattern that we see among these measles cases, and particularly among the large outbreaks of measles in the US, is that they were initiated by travelers to areas that where measles is circulating, either in a large outbreak setting, either domestically or internationally, then coming back home and again, spreading measles in their communities where there are pockets or groups of individuals that are unvaccinated. And again, that's the typical epi-pattern that has been seen with the large outbreaks, again, particularly in New York, also in Washington as well. And I was really surprised to see, and you may have seen this as well, when speaking of everything old is new again, I was frankly surprised to see that in Los Angeles and also in a cruise ship, they actually instituted quarantine measures, which is a very ancient public health practice technique to try to prevent the spread of communicable disease among individuals that are exposed to an infectious disease and may not have developed symptoms yet. But again, 2 universities in Los Angeles and a cruise ship in St. Lucia actually quarantined individuals in facilities until they could document that they had immunity to try to, again, they didn't have measles and they didn't have symptoms yet, but to try to, again, lower the chance of spread. So I thought that was surprising. Actually, at a cruise ship, folks, there were 28 people that were still under quarantine as of yesterday. They just came out of quarantine. That was the last day. So what about here in Georgia? So for us in 2019, we've actually also experienced measles outbreaks, actually 2 of them. And the reason that we have experienced measles outbreaks is that by CDC definition, 3 cases of measles linked in time and space is considered a measles outbreak. It's more than we usually expect. So we've had 2. We've had 2 outbreaks of 3 cases each here in Georgia. One was in January and one was in April. And again, in both of these situations were very similar. They were both confined to single families. And so they were single families, children, siblings who were unvaccinated. The first 3 was one family. The outbreak in April was also a family of 3 siblings. Both of them, again, resulted from travel to areas where, again, measles was circulating. So ultimately, our overarching goal, as it is with any measles case that we deal with, is really, again, try to rapidly identify any exposed contacts, particularly those that may be susceptible to measles, and then either offer prophylaxis as appropriate, educate them about the symptoms of measles if we're beyond the window for prophylaxis, and say, if you develop these symptoms, again, we want to be sure primarily that you don't walk into an emergency department with these symptoms. We want you to call the provider or call public health, and we can facilitate you being seen safely so that you don't expose others. It's all about, again, trying to limit potential exposures to others when symptomatic as well. We're very fortunate to report that we really did not document any secondary cases of measles in either of our 2 outbreaks. We were fortunate because, again, in these situations, the case patients, these children that were involved, were not, again, in very many, sort of widespread venues. And also, again, we were fortunate that, again, they were not, primarily among communities that were unvaccinated as well, resulting in further spread. So we were glad to see that these situations were very, very contained, fortunately. But no matter what, whether it's a single case or a large outbreak of measles response is extremely labor-intensive and very, very time-sensitive. In each of these situations, there may be hundreds of people that potentially could have been exposed in these areas. And again, we have to try to find out and track down whether any of these individuals are susceptible or not. And it really ends up being very costly, both in public health costs and also in healthcare costs as well. I found a very interesting study recently published in Vaccine that, and also by the state of Arkansas as well, that really estimated that the cost of response to a single measles case here in the U.S. was almost $50,000. I found that to be really staggering. And if you think about the 839 cases of measles that have been documented in the U.S., it adds up very quickly. So how do we mitigate that cost? Well, I have a pretty simple idea, and you see it on the slide. We want to promote, certainly, vaccination, widespread vaccination as much as possible. The other thing that I just wanted to briefly mention to you, again, we in many of our health departments, we're getting a lot of questions about whether in the context of these increases in measles cases, do adults actually need a booster dose of MMR or measles vaccine? And CDC essentially weighed in on this last week and said that no, there is not really any need for any widespread recommendation for a booster dose of MMR among adults. That the recommendations from the ACIP from 2013 have not changed, but that indeed there may be some risk-based reasons why an adult may want to ensure that they indeed are immune, meaning having 2 doses of vaccine. And that might be, for example, a small percentage of folks who received a kill measles vaccine in the mid-1960s, or if an individual works in healthcare or is traveling internationally to an area where there's a large measles outbreak, it may be prudent to try to, ensure that they are either immune or get a booster dose. But it's all sort of risk-based. But across the board, there's not really a widespread recommendation from CDC that all adults should get a booster dose. Number 3 in the trilogy. So this one is a multi-state outbreak of E. coli infections that, again, is really very, very large. So the way this unfolded was at the end of March, the DNA fingerprinting that was performed and is performed routinely at public health laboratories really showed a large increase in the detection of Shiga toxin producing E. coli organisms that are of the strain that is called O103. And again, that was initially reported by Kentucky and here in Georgia as well. We saw, this is a relatively uncommon strain of E. coli, and again, we really see it quite rarely, and we saw a great increase in place and time here in Georgia during March. And over the next month or so, CDC and public health labs actually confirmed a total of almost 196 cases of O103 infections in 10 different states. And we have had a total of 49 here in Georgia. It's huge. This is our largest, certainly our largest E. coli O103 outbreak ever, but really one of our largest Shiga toxin producing E. coli infections ever as well. So what's E. coli O103? So it's a bacterial pathogen that's similar to E. coli O157H7. That's the one that most people are familiar with. But again, it's much less common. These E. coli organisms are held in animal reservoirs, and we know that for O157 that cattle are the animal reservoir. They don't get sick, they just carry the organism. But for O103, it's a little less clear what the animal reservoir is. It's been found in a number of animals, sheep, cattle, deer, and some others as well. And again, the largest outbreak prior to this one in the US was in 2010 in Minnesota. It was associated with venison. But these infections really can be very, very serious. These Shiga toxin producing E. coli, they actually can result in a type of renal failure that is called hemolytic uremic syndrome, or HUS, and they can even result in death. So clinically, these infections are very severe. O103 is thought to be a little less severe than its cousin, O157, but no matter what, whenever we have a large outbreak of what we call these Shiga toxin producing organisms, we treat it as a public health emergency because of the potential severity of these infections. So that's the background, but here's what we look at nationally. So there's been a total nationally of 196 cases, and it's in 10 different states. The states that have the highest number of cases are Kentucky, Tennessee, and us in Georgia as well. And again, this outbreak unfolded from the beginning of March kind of through the middle of April. And again, if we look at sort of the epi snapshot, again, about 50% of infections are half and half, male and female. The median age is 19. 16% of them have been hospitalized. No deaths have occurred nationally, and only 2 cases of HUS. So this is good news in that way, as far as the clinical severity goes. And remember that O103 infections can indeed be a little less severe than O157, but this is a huge outbreak. And if we look at our data here in Georgia, it really mirrors the national data. And again, our onsets were just a little bit later. We were really tightly clustered, kind of mid-March to the end of March, although we've had some onsets in April as well. If you look at this national epi curve here, if you kind of look at the highest peaks, the peak of the outbreak really was mid-March or so, and it looks like it really is kind of trailing off a bit. Although, again, because of some of the delays in testing and in reporting, we again probably will expect to see some additional cases, but their onsets probably will indeed be, in April rather than, sort of ongoing now. In Georgia, as far as our 49 cases, 6 of them were hospitalized. We've had no deaths, no HUS cases. So what was the culprit in this? So we look at this national investigation, the national epi investigation. Again, the epi investigation actually statistically implicated consumption of ground beef to be associated with illness. So again, it's clear that, again, an organism like E. coli O103 can also be found in cattle reservoirs as well. And when case patients were interviewed about where they ate their ground beef, there was a variety of responses. A number of different restaurants bought them at a number of different grocery stores. And really what cracked the case open was our neighbor in Tennessee. The Tennessee State Health Department actually collected an unopened package of ground beef from one of the restaurants in which several cases in Tennessee had eaten, and they tested the ground beef, and it actually, again, had E. coli O103 that matched the outbreak strain and matched the same strain that was found in their case patients as well. So then they were able to actually look at where did this ground beef come from in this restaurant and trace it back to where it was produced. And it turned out that, again, there's always a Georgia connection to everything. It turned out that this particular ground beef was actually produced in a company in Carrollton, Georgia, or a plant in Carrollton, Georgia, that is known as Colorado Premium Foods. And so when a tracement like that occurs, essentially they issue a recall. The company issued a voluntary recall. Also, they recalled about 100,000 pounds of ground beef, and another company, actually in Illinois, also recalled beef due to potential O1, O3 contamination as well. So that is all a good thing, and that is a good, mitigating strategy to stop these outbreaks. But ultimately, there's been really no single supplier, distributor, or brand of ground beef that could account for all of these 196 cases. So not everyone, again, consumed ground beef in restaurant settings. The 2 recalls were related to ground beef that had only been shipped to restaurants or institutions. But there were many of the case patients that ate ground beef only at home. So again, this investigation is still ongoing and trying to sort of link. I suspect that the contamination, was certainly wider than just these 2 companies, and again, also went to retail as well. And that is still ongoing. Those traceback investigations can be also pretty labor intensive and they take a lot of time. So in the meantime, as the investigation proceeds, and I really do think it's winding down, but no matter what, whether it's winding down or not, consumers and restaurants always, again, as a matter of prevention, should be reminded of the very importance of handling ground beef safely and cooking it thoroughly. And that's it for me. Thank you again for your very kind attention.
Thank you, Dr. Menzies, as always. We remain educated. Does private and public funds pay for the measles vaccines?
Yes. All right, thank you all. Thanks very much.
Any other comments that we want to make? We want to amend, our next board meeting in June is canceled, but we will meet in July. So the June 11th board meeting is canceled. We continue to appreciate everyone's participation and time and presentations that we enjoy and comments. And I think we will move forward adjournment. We have a motion.
Second.
All in favor? Thank you so much. Now, we're going to go into executive session.